Dear colleagues, I would like to hold my presentation. So my PhD topic is cervical disease and their connection with clinical and health factors. I'm a resident doctor at the Department of Obstetrics Gynecology, Semmelweis University. My vision is that primary HPV detection-based cervical cancer will be implemented in Hungary in the next 5 years in the above 30 years age group. My mission is to change the Hungarian guidelines on cervical screening and treatment. I have two specific goals to achieve this. These are my ongoing projects. The first is titled Trichomonas vaginalis infection is associated with increased risk of cervical carcinogenesis. So this is currently the status of this manuscript. So now it's currently under submission in the International Journal of Gynecology and Obstetrics. So some backgrounds, probably you have all heard it. So lifetime prevalence of HPV is 80%. It's necessary but not sufficient for cervical cancer. Trichomonas vaginalis infection causes inflammation and decreases protective barriers of the vagina and cervix. And this inflammation of the cervix might cause persistent HPV infection and contribute to cervical carcinogenesis. And our aim was to assess the effect of Trichomonas vaginalis infection on increased risk of cervical carcinogenesis. This was our 2PO framework. So our hypothesis was that Trichomonas vaginalis infection increases the risk of cervical carcinogenesis. We did systematic search last year. Flowchart of our selection, we had 29 eligible articles. So some of the results from our manuscript. This is figure 2. This is a forest plot. The study is representing that Trichomonas vaginalis is associated with HPV infection. Now we will see cytological aberrations. First is with high-grade squamous intraepithelial lesion, and once again there was a correlation between or association between Trichomonas infection and HCL. Now this is cervical cancer, and we've seen an association between Trichomonas vaginalis and cervical cancer. So women who were Trichomonas vaginalis infected had increased odds for the diagnosis of cervical cancer. And this is our second PICO. The population deals with only HPV positive women, and the outcomes were cytological anomalies and cervical cancer. And in all cases, we found a significant association between Trichomonas vaginalis and these outcomes. So some strength of this meta-analysis. This is the first one that investigated Trichomonas vaginalis and HPV infection and different cytological aberrations. It has a huge sample size, nearly 500,000. It's globally representative articles from all around the world. Of course, it has several limitations. These studies are mostly cross-sectionals, and cervical cancer can have many, or it has many risk factors, but we had very little control on the confounding factors. And in some cases, we experienced high heterogeneity. So, some conclusion, detection of HPV infection and cervical intraepithelial neoplasia is increased in the Trichomonas vaginalis infected population. In the subgroup analysis, there were big differences between the odds ratios, and the highest odds ratios was with the detection of PCR and wet mount. So some implication for practice. We strongly suggest to screen and treat for Trichomonas in case of a positive HPV infection or a positive HPV test. And for implication for research is it would be great to have studies where we have more control on the confounding factors, because this is one of the main limitations of our study. And it would be interesting to know the confounding factors and have this study. So moving on with the second project, the effect of topical imiquimod treatment on reducing cervical neoplasia. So some background of this topic. Guidelines recommend surgical therapy for cervical high-grade squamous intraepithelial lesion. And around 90% of cases, HPV is responsible for these lesions, but surgery doesn't necessarily treat the infection. And topical imiquimod is an immune response modifier drug, which is used and approved for genital warts, basal cell cancer, and actinic keratosis. And in one study, imiquimod fastens HPV clearance by 60% compared to the control group. And our aim was is to assess the efficacy and safety of topical imiquimod therapy on reducing cervical intraepithelial neoplasia. So this is our so the clinical question is, what is the response rate to topical imiquimod therapy in cervical intraepithelial neoplasia? And we used two frameworks. It's because in some cases we didn't have a control group, so we were interested in the response rate and adverse event. We used the COCOPOP framework for this, and when we had the control group, we used the PICO or PICO framework, and we were also curious about the response rate and adverse events. And our hypothesis was that topical imiquimod treatment is effective on reducing cervical intraepithelial neoplasia. We did our systematic search and we found 9 eligible articles, and currently we are in a phase of, we have finished data extraction and we will send it to the statistician, but we also started the risk of bias assessment and the grade. So I hope that we can finish this project in the next month. Thank you very much for your kind attention.
Congratulations, Balázs. I would have just one question, short, that do you think it can happen that if someone has trichomonas, then they will have symptoms, or in most of the cases, as I know, so bothering symptoms. So can it lead to a potential selection bias from the articles that these patients are go more frequently to see a doctor, and when they are there, they will be screened for other STIs as well, and then it turns out that they have HPV as well, or what do you think of this topic?
Well, in many cases, actually, trichomonas is asymptomatic, and in many cases, these were screening tests, so not all cases women have symptoms. So it's very important to clarify that in many cases, these were there were studies, and there were just epidemiological screenings. So if it answers to your question.
Yeah, so the designs of your studies excluded this bias?
Not exactly. We didn't have an exact control on this question, or but it varied between studies. So, but mostly studies were designed to be for screening. So yeah, they were screening.
Thank you very much. Congrats again.
Thank you.
Congratulations, Balázs. I have 2 questions related to your second study.
Yes.
So when we checked these RCTs, there were RCTs and cohort studies on this topic. In case of the RCTs, we saw that there were huge differences between the intention to treat and per protocol results. So could you just say a couple of words why this happened? So why was there a huge loss of follow-up? And also, we are assessing the adverse events, which will be the adverse events that you could see with this data extraction. So what is happening after getting this topical imiquimod therapy. So what are the adverse events that we will check during the analysis?
So to respond for your first question, why is there a huge difference between per protocol and intention to treat? So if a drug has an adverse event, it means it has an effect. So we know topical imiquimod sure has many side effects. So therefore there were many patients who left the follow-up and that's the reason and the difference between the intention to treat and the per protocol was basically of adverse events. And could you reply your second question, please?
What are the adverse events?
The adverse events, you mean? Yeah, so this is an immune response modifier. So it has like flu-like symptoms, fever, headaches, myalgia, also fever, and some local side effects as well. So, yeah.